Probably the biggest unmet need would be point of care monitoring. So oftentimes in the outpatient setting, to get a stat lab back, it takes too long at many centers or offices. So having the ability to run a finger stick TLS panel or a point of care test, I think would probably be the biggest unmet need. Second to that would be availability of uric oxidase, because this is an expensive drug. And so it may not be on formulary or be available to everyone. And then probably, I would say third on the list would be STAT G6PD testing, so that if you need to use respiricase, you know that the patient is not G6PD deficient. And I think that's a mandate for use of the drug, and certainly is at our center. My best advice is to do everything you can in terms of prophylaxis and monitoring so that it doesn't happen in the first place. If it does happen, of course, escalating a patient to the hospital or even ICU is never the wrong decision. And always involve subspecialty partners like cardiologists, electrophysiologists, or nephrologists early on in the course, because they can be very helpful in managing this.
What drugs are in development for tumor lysis syndrome? And unfortunately, the answer is not many. There are some other agents that have been developed for the treatment of gout and for patients with severe and chronic gout. One is febuxostat, and febuxostat is also a xanthine oxidase inhibitor, just like allopurinol. The nice thing about it is it appears that the allergic reactions to febuxostat is less than that of allopurinol. So that would be one, because there are some patients who have allopurinol allergies, and so this might be a better drug for that. There's also, in terms of uric oxidase inhibitors, there is another, there's a pegylated form. I'm actually gonna have to read it out to D-glucoticase. It's also used for hyperuricemia. But it's not specifically indicated for tumor lysis syndrome. And it works by the exact same mechanism as that of rasburicase. So really in this, there people are looking at other agents that lower uric acid levels. And that's usually, there's a larger patient population with gout. So these agents are available today, but there's really not a ton of work being done at this point in time relative to new agents for tumor lysis syndrome, which is really a very niche complication. My advice for community oncologists, I'd like to think about, instead of treating TLS, I'd really like for community oncologists to be thinking about preventing TLS. And so the most important thing is the recognition of patients at risk for tumor lysis syndrome. Be thinking about, once you do identify those patients, how high the risk is, and the two most important when you determine that patients are at risk for tumor lysis syndrome is hydration, and hydration with good urine output, and then thinking about measures to prevent hyperuricemia. And again, the two drugs to go to are allopurinol and rasburicase, and your decision in using those are really going to be how high the risk is, and that every patient should be considered a potential at risk for tumor lysis syndrome, because as I mentioned before, you can see it in solid tumors, you can see it in hematologic malignancies, but there are certain entities which present themselves to be at higher risk. So trying to prevent tumor lysis syndrome is the most important thing that we can do.